Hey everyone, and welcome back to the channel. Today we are continuing with the CPC review series. In this section, we're going to be covering ICD-10-CM chapters 1 through 11, which coordinates with chapter 4, I believe, of the official CPC curriculum. If you're using just a general medical coding curriculum or the Buck step-by-step curriculum, it might be a different chapter. I want to say chapter 4 or 5 maybe for Bucks. As a reminder, in order to have the best use of this review, you do need to have medical coding books. I can't give you those books because copyright issues. And this is intended to be a recap of things that I just want to say should stick out to you that you want to highlight or focus on during your preparations for the CPC exam. The CPC exam is a huge exam, so I can't say for certain, oh yeah, this test question is going to be on it because I'm guessing at least 1,000 questions in the test bank, and you get a randomized 100 questions. So there are certain concepts that they are more likely to have test questions for because they're something that are important. So I want to highlight those particular concepts that we want to focus on because they are more pertinent in the study materials and are more likely to appear in one of those test questions. But again, they might have like 5 or 6 questions that test on the same concept. Not saying there's 5 or 6 questions on your exam, but 5 or 6 questions in that whole exam bank, meaning you could get one of the multiple questions that test on this concept. Oh, yeah, by the way, if you're new here, I'm Victoria Mole. I'm a medical coder, auditor, educator, and content creator. And on my channel, I provide lots of tips, tricks, and tutorials to help you be successful in your medical coding career. If you haven't already, I highly encourage you to subscribe, hit the notification bell, do all the YouTubey things, and share this with your students, your fellow coding friends, and more. In any case, I want to start out going chapter by chapter through ICD-10-CM. Now we're going to cover 1 through 11 in this video, starting out with our chapter 1. So chapter 1 covers infectious and parasitic diseases, and it has a focus on coding for things like HIV and sepsis. So when we're thinking about our HIV coding, it's important to remember that B20 is used for symptomatic HIV cases. Z21 is the one that we use for our asymptomatic cases. Also, if the patient has an opportunistic infection that's related to HIV, you need to code the B20 first and then the infection. If you're looking at B20, it'll give you those directives. It'll say, hey, don't forget, also code for the infection. Sepsis is another big topic. It's sepsis. Yeah, sepsis is always a big topic. Don't forget to code for the underlying infection if it's known and follow up with the R65.2 and then that additional fifth character. If organ dysfunction is involved, you need to know the specific organ dysfunction in order for it to qualify for severe sepsis. When you hear severe sepsis, you need to think, oh, organ dysfunction. If you don't see an organ dysfunction and you can't code organ dysfunction, it doesn't qualify as severe sepsis. Also, keep an eye out for those MRSA codes, especially Z16.11, and how to handle special cases too, like Zika virus and COVID-19. Now, COVID-19 is a little bit easier because there's only one actual confirmed COVID code, but they might kind of try to trip you up with maybe some testing or some signs and symptoms type stuff. Remember, if we have a confirmed condition, we code the confirmed condition. If we don't have a confirmed condition, if it just says the patient's having shortness of breath and fevers, and we don't have a definitive diagnosis, we use the signs and symptoms. When we move on to chapter 2, that is our neoplasms. So our growths, our cancers, our lumps and bumps. So one of the important things to remember here is how to code for our primary versus secondary malignancies and how we organize them as far as which comes first, which comes second. Let me take a second here, though, and talk a little bit about the neoplasm tables. I'm going to get out my ICD-10-CM book. So here's my ICD-10-CM book. I'm at my neoplasm section. And if we're looking for our neoplasm table, though, we have all our guidelines here. Depending on what edition you have, you should have the neoplasm guidelines and their chapter specific guidelines at the beginning of that chapter. But we need to find the table of neoplasms because we got to talk about that. Now, currently, I have this book tabbed. I'm not a big tabber, but I do it a lot for demonstration purposes for you guys. So when we're looking at our neoplasm table, you're not going to look under the word N in your alphabetic index. Um, There's certain neoplasms that have their own alphabetic index entry, for example, in actinic keratoses. You can look under keratoses. But if we're talking about cancers, we're talking about neoplasms, we're talking about primary, secondary, carcinomas in situ, benigns, etc. We're going to need to know where our neoplasm table is. It comes right after your alphabetic index in most editions. This is the AAPC edition. You might have a Bucks edition, you might have an AMA edition, you might have an AHEMA edition, you might have an Optum edition, and those have all the same codes, but things are organized differently, and you might have different illustrations and things. So my publisher edition is AAPC. So you can see here's the very end section of my alphabetic index, my XYZs, and then my very next page, excuse the coffee stain, is my neoplasm table. So we have different columns here in the neoplasm table to follow, right? We have malignant primary, secondary malignancy, carcinoma in situ, benign, uncertain behavior, and unspecified behavior. So for our primary malignancy, that is where the cancer originated from. So where it started, the first site of the cancer. Secondary malignancy is where has that cancer spread to? So did it go from the ovaries into the uterus? Carcinoma in situ is a cancer that is kind of isolating itself to its spot. It's not really spreading or growing outside of its place of origin. Benign is non-cancerous. And then what trips people up is this difference between uncertain behavior and unspecified behavior. Uncertain behavior is we analyzed this, we took a look at it, we put it under the microscope, we tried to figure out what this is. We're just not sure. We don't know what this is, but we did try to figure it out. Unspecified behavior is no one documented what this is. The provider didn't say that this was a keratoses, that this was a mole, that this was a cancer. They didn't specify. They didn't tell us. So uncertain is we tried to figure it out, but we don't know. Unspecified is we're not saying. So that's the difference between those two. Now, again, talking about neoplasms, and again, this is why the tabbing is nice because I can flip right over here and be like, oh, here I am. I'm in my chapter specific coding guidelines. So, really important to go through these guidelines, understand your sequencing, especially with things like administration of chemo, immuno, and radiation therapy. For example, if a patient's coming in for treatment for chemo and it's focused on a secondary or metastasized site, that's what gets sequenced first because that's the primary reason that they're getting treated that day. So, really pay attention to that and as far as sequencing things. All right, moving on to chapter 3. That covers diseases of the blood and diseases of the immune system. So, nutritional anemias like iron deficiency, they fall under those D50 through D53s, while our sickle cell disorders are under the D57 range. Aplastic anemia, that involves the body not producing enough blood cells, and those are our D60 through D64 range. Chapter 4 is all about endocrine, nutritional, and metabolic diseases, with diabetes being a key focus. So you'll use E08 through E13 for coding for diabetes, depending on the type and the cause. So, for example, E11.9 is our type 2 diabetes without complications. But if the patient's on insulin, we can't forget to add Z79.4 for the long-term insulin use. It's really crucial to know how to code diabetes complications such as retinopathy and nephropathy, and also remember that gestational diabetes takes precedence over diabetes coding and when we're coding for pregnant patients. So all those obstetric codes, they take sequencing priorities. The other thing I want to mention as far as diabetes coding is we can't forget our general coding guidelines and the term with and what that means in coding. If the default is not documented, if they don't say it's type 1 or type 2 diabetes, do you remember what type we use? It's type 2. So if the provider does not document what specific type of diabetes is, the default is type 2. Now, as far as the width, if we look here under diabetes and we follow the next alphabetic indentation, it's not the thing that comes up next in the alphabet. It's actually this term with, and there's a very important reason why. So anything that appears here under the term with in the alphabetic index is assumed to be related even in the absence of provider documentation linking it. What do I mean by that? So let's say the provider says diagnosis 1, diabetes. Diagnosis 2, Foot ulcer. Instead of just coding diabetes and then coding a separate foot ulcer, we use our combination code, diabetic foot ulcer E11.621, because we have an assumed cause and effect relationship by anything that is linked with the term with in the alphabetic index or the tabular list. So when we see this term with, anything that comes under here, even if there's documented as separate diagnoses, we can assume that they're related unless the provider specifically says this is not related to the diabetes. So if the patient says, or the documentation for the patient says diagnosis one, diabetes, diagnosis two, a big one, chronic kidney disease, we assume that they're related. That it's diabetic chronic kidney disease, E11.22. These are the type of concepts that they're going to test you on for the CPC exam. It's not just going to be simple code lookup, it's going to be understanding how to apply things like this. All right, moving on to chapter 5. So, chapter 5, we tackle mental and behavioral disorders. Some of the critical concepts here is to remember the hierarchy for coding substance use. If both use and abuse are documented, we code for abuse. If both abuse and dependence are documented, we code for dependence. We also have depression covered in this section. That's a lot of our F33 and I think F32 codes. And you need to pay attention to the episode, like is it mild or is it in partial remission? For bipolar disorder, the codes are based off of whether the current episode is manic, depressive, or mixed. Sometimes they like to test on fictitious disorders. So the differentiations that we're going to kind of want to look for, like if we're looking at something about fictitious disorder, we want to see is this self-imposed or is it imposed on someone else? So keep an eye out for those differentiations in those codes. Chapter 6 focuses on diseases of the nervous system. A lot of emphasis on pain coding. So G89 codes to distinguish between chronic pain, postoperative pain, neoplasm related pain. For example, G89.3 is used for neoplasm related pain regardless of if it's chronic or if it's acute. When coding for postoperative pain, G89.18 is used if the pain is not routine. And be sure to know the default coding for acute postoperative pain. Chronic pain syndrome, which is coded with G89.4, should only be used when it is specifically documented by the provider. Chapter 7, you need to focus on coding for diseases of the eye, particularly glaucoma. Glaucoma is coded by type, laterality, and stage. So, for example, H40.1134 is used for primary open angle glaucoma with indeterminate stage. If both eyes are affected and the stage and the type are the same, we can use the bilateral code. However, if each eye has a different type or if they have a different stage, we need to code for each eye separately. We can only code them as bilateral if both eyes have the same type and the same stage. Again, common concept that comes up on all the CPC prep material. So, one that is more likely to get tested for with the exam. So, make sure you're familiar with that. Chapter 8 focuses on the ear and mastoid process with common conditions like otitis media, mastoiditis, and otitis media refers to ear infections. It's coded based off of whether it's acute, chronic, or serious. So, for example, H66.001 is used for acute suppurative otitis media without complications in the right ear. Mastoiditis is an infection of the mastoid bone behind the ear, and it has its own set of codes like H70, which you need to code any complications for very carefully. Additionally, hearing loss and tinnitus, so our H91, H93, they are important in this chapter. So H93.11 is for tinnitus in the right ear. And keep in mind that the level of detail of documentation is really what's going to guide you to the most specific code. We have unspecified codes, but really in most provider documentation, if a patient's having a problem in their right or left ear, they should be documenting if it is the right or the left ear. But make sure you're really reviewing that documentation and making sure that there's no conflicting information and that we're documenting to the appropriate laterality and any appropriate complications. Chapter 9 is all about diseases of the circulatory system. One of the most important concepts here is your hypertension coding. I-10, probably the first code that most people memorize, right? Because the code set's called ICD-10, and you learn that I-10 is hypertension, and you go, haha, learning ICD-10-CM and learning medical coding will give you hypertension, right? So if we look at our Chapter 9 guidelines, there's a lot of guidelines here pertaining to hypertension. One of the big things that they focus on is if it's hypertension and heart disease, we code from category I-11, not I-10. Hypertension and chronic kidney disease is I-12, and then I-13 is when it's hypertensive heart and chronic kidney disease. We have to pay attention to things like if it is chronic kidney disease, yeah, we have a combination code, but ooh, that combination code does not include the stage. So we also have to use a code from N18 just to designate what is that stage of the chronic kidney disease. Is it stage 4? Is it end stage? What is the stage of the chronic kidney disease? Same thing with the heart disease. We have hypertensive heart disease, but we want to know, says to use an additional code, category I-50 from heart failure to identify what is going on with heart failure. So really pay close attention to these hypertension guidelines. Read through your guidelines. For heart attacks, we have our ST elevation MIs, our STEMIs, and those are coded I-21, while our non-ST elevation myocardial infarctions and STEMIs are used with I-21.4. We also have our stroke codes in this section, so our I-60 through I-69 range, and you have to really carefully review the type of stroke and if there's any lingering effects. Also understand that in order to code a stroke, it has to be that the patient is actively having a stroke, or if we're coding for facility coding, the stroke code carries throughout the entire inpatient stay. However, this is a pro fee coding exam, the CPC. So if the patient's coming in for their annual wellness exam, it's unlikely that they're having a myocardial infarction that day. It's possible, and in which case they would be admitting them to the hospital. But if you see something that says patient is here for transition of care or follow-up from a stroke, that doesn't mean they're actively having a stroke. So we're going to code that as a past history. We're going to code that as whatever residual effect that they're having. Chapter 10 covers diseases of the respiratory system. COPD is a major focus here. Chapter 10 covers diseases of the respiratory system. So COPD is a big focus here. That's coded under our J44, but pay attention to if the patient has asthma or an acute exacerbation of their asthma. Asthma is a big key area. You need to code based off of the severity and complications, such as J45.21 for mild persistent asthma with acute exacerbation. Pneumonia is a big one for the CPC exam as well, with coding dependent on the organism that's causing the infection. And then, if they don't, we have an unspecified code. J18.9 is our catch-all code for the unspecified pneumonia, but we always want to look for anything else that might be somewhere in that documentation that specifies it. Sometimes they might not say it right next to it. They might not make it obvious. They might put it somewhere else in the documentation because this is an examination where they're testing you. They want to really see if you're going to be proficient and demonstrate all of your appropriate skills that you can use in this field. And then chapter 11 is our diseases of the digestive system. Here we see a lot of things like our gallbladder diseases, cholelithiasis, cholecystitis. Hernia coding has changed recently in CPT. It's something that I would say is likely to come up on the exam, some kind of hernia code. Those are pretty common type of procedure. So pay close attention to if it's an inguinal hernia, if it's an umbilical hernia, if it's a recurrent hernia, or if there's complications, if there's an obstruction, if there's gangrene. So that covers the majority of chapters 1 through 11. This is not intended to be a full comprehensive, I'm teaching you medical coding, but this is like, okay, you've studied this chapter. You're either going to prepare for your exam now, and here's some key things to focus in on. Or, I just finished this chapter and I'm all over the place. Like, what are the key things I need to keep in my mind? But let's go through a couple of practice questions here. So, starting out, when a patient with symptomatic HIV comes in and they present, when we're coding for them, what of the following codes should be used? Is it A, Z21, B, B20, C, R75, or D, Z11.4? Going to give you a second. look it up, pause the video, and then we're going to go through the answer. B20 is the correct code for symptomatic HIV. The Z21 is our asymptomatic. R75 is for inconclusive lab evidence. Z11 is for encounters related to screening for HIV, but not confirmed symptomatic cases. Next question. A patient is diagnosed with a malignant neoplasm of the left breast lower outer quadrant. Which of the following is the correct code? Now, this is one where we have to look in our neoplasm table. So here we go. Here's our neoplasm table. We're over here in breast, and this question was testing us on malignant neoplasm, left breast, lower outer quadrant. So here we are, breast, lower outer quadrant. And what it does is if you see here, it gives us C50.5 and then a dash. So what does that mean? That means we need another character. So we have to go to our C50.5 and we have to check for our additional character or characters. So here we are, C50.5. And this again was the left lower outer quadrant. So we're here on lower outer quadrant, left outer quadrant. So in that case, this one is our C50.512, which is our answer D. Next question is, which of the following is appropriate code for a patient with type 2 diabetes without complications who uses insulin? So what did we say about patients who are using insulin? We need an additional insulin use code. So this is one where we could like process of elimination a couple of codes. Like if we just know off the top of our head that insulin use means that we need a code for insulin use, we could just go, oh yeah, it's not this one, it's not this one, and it's not this one. And we could pretty much eliminate that and go, oh yeah, it's E11.9, Z79.4. Diabetes is one that people memorize a lot too. Of course, coding is not about memorization, but there's certain codes that get used so frequently that you tend to remember them. So if you can even remember that the code for default type 2 diabetes without complications is E11.9, you could even narrow this down to A or B. But in this case, when we're looking for that, it is our E11.9 and the Z79.4 for our insulin use. The E10, I believe, is a type 1 diabetes code, and then the E1165 is for with hyperglycemia, and that doesn't apply here. They didn't say anything about the patient having hyperglycemia. Next, a patient presents with severe sepsis and acute kidney failure. Which of the following code combinations is correct? So this is one where we're looking at it and we're going, okay, well, there's a sequencing differentiation here. So here we can see some of these, like we have an R65.2, but then here we have an additional character extension. Here we have these sequenced differently. A49.1 is secondary here and it's primary here. So this could be one where we could narrow some things down just even based off of sequencing. Also, it says here the patient has acute kidney failure. I have worked with hospitalists enough that I know that a code for acute kidney failure is N17.9, so I can eliminate A right away. If you remember just kind of going through in generalizations about our infectious disease codes, so sepsis is part of our chapter 1 codes, which are all of our A codes. So likely that it's probably gonna I'm thinking A or D, just kind of looking at it. But if we look this up, our A41.9 is our unspecified sepsis. If you look under the code for sepsis, it says to code severe sepsis followed by the acute kidney disease, which in this case would mean it is our answer D. So we have our code for our sepsis, our severe sepsis, and then the organ dysfunction that we need to have in order for it to qualify as severe sepsis, which is our acute kidney failure. Hope you guys enjoyed this review series. I'm going to be continuing it. I'm hoping to do some refreshers. I know I have a whole CPC review series already, but I feel like it just needs a little update every couple of years, even though there might be very small minimal changes. It's just good. People like to see that there's updated ones. So if you're a teacher and you're using like Links to my videos, you might want to make sure that you're doing it to the most updated edition. If you guys have any questions, definitely let me know in the comments below. I will see you guys in the next video. And until then, just keep on coding on.